I've been very fortunate to work in India for the past 12 years, both as a clinician and as a researcher. I've worked with some very inspirational people whilst I've been in India. The thing what started off my interest in suicide and self-harm was not just working as a clinician in mental health or in psychiatry in the UK, but was when we visited general hospitals in India and found that 60 to 70% of the intensive care units were occupied by people who had attempted to take their lives. There was a shortage of ventilators, and this was in 4 general hospitals in one city in southern India. And if you think about that for a moment, 60 to 70% of the intensive care beds occupied by people who had attempted to end their life, largely by ingestion of organophosphates, so pesticides, which was the availability of the means to harm yourself, and it also did a very good job of ending the person's life, if not detected within the first, say, 6 to 8 hours. So this fascinated me, it intrigued me, and it started me to ask a range of questions. So we've talked about individual differences this morning and the complexities of suicide. That the person who self-harms or commits suicide, it's a very individual, but there are biological reasons, psychosocial, and also cultural reasons. So why I called this presentation an outsider trying to become an insider, was that it was in another culture. It was working with different parameters of healthcare services and treatments. For example, there was no community mental health teams in the state where I was working at. There was very little in preventative work. So you have to decide where is your intervention point. And we decided it was from accident and emergency to intensive care and then beyond setting up follow-up care. So it was a sensitive subject that requires compassion, understanding. It has many facets to it that I don't think we can ever understand as clinicians, as professionals, as individuals, as members of society. But the aim was to gather evidence to inform practice within another culture, and I was always very sensitive to that. I worked with people in India who I'd also worked with in the UK, who had returned to India, and we'd maintained those relationships. But importantly, this had to be locally owned, not an outsider coming in and saying this is how you might do it, and it had to be locally sustained. So we still supervise the clinicians we trained in 2012, and we still follow them up remotely on a 6-weekly basis. We have clinical exchange groups. This one was with my psychology colleague over there, but also one of the first persons who attempted to harm himself, who we followed up and had community mental health team support. This is important, and this always reminds me of a cup of tea, because one thing he said was, after I'd attempted to kill myself and ingested pesticides for a relatively small debt, this was £35 in an English equivalent amount into rupees, he struggled to get cultural acceptance. His family still acknowledged him, but his friends and peers did not. They would not have a cup of tea on a tea stand on the corner of the street where he'd previously worked. So he had months, possibly up to 2 years of isolative behaviour from his society. And this is why you think something as small as a cup of tea and a conversation and some acknowledgement goes a long way. It's not that India has different problems to the UK. It's just the scale of the problems is a lot more visible, and the issues and the challenges and the dilemmas. I think it's a lot more stark, but it's the same in most cultures with it. The good thing about it is that he now owns his own business. He employs 4 people, and this was not massive amounts of mental health support following an attempt. It was very routine, what some might call basic, but it was that acknowledgement, that ownership, that being part of something that was crucial. You've got the shame and stigma associated with harm attempts, irrespective of which culture or which country it's in, and the isolation that accompanies it. Discussing self-harm and suicide actually reduces the severity. And I think there's a feeling within professionals that if you would talk about it, you increase the intent. It's not, it's actually counterproductive. It decreases the drive, it decreases the intent. So it's important to discuss it. Problem solving on the path to recovery. In the case of the person who you saw there, it was financially driven. There was some element of mood within there, but the reasons are vast, they are complex, but it might be just one thing that starts the person on that road to recovery. We also then established a research team. There's Santosh, my colleague Paul, and Murali, who I work with still. He was my key contact in India. And we established a research team over there in Holdsworth Memorial Hospital. We also applied for a few grants and were successful, and we also trained trainers to start disseminating training in general hospitals. One thing that I found is this really inspires you, it really gives you passion, it really gets you interested in it, and it came at a time in my career when I needed that. I came back enthused, energized. I'd spent 3 weeks in India. My wife said, 3 weeks, you've been on holiday. And I said, I was up at 7 in the morning and I was working till 7 at night, and it was 7 days a week. Even going back to the airport, they'd arrange meetings for us in Bangalore. It was very intensive. It was not a holiday. There was no days of rest. This is something I should do different next time. My wife came with me about 4 or 5 years later, and she goes, yeah, I see what you mean. I don't want to do that again. It was very busy and very full on. This, when you read the press over there, though, we got the Times of India every morning, and it raised the issue of, you know, you're looking at their rupees per tonne of the crops. Now you think, what's rupees per tonne of the crops got to do? Well, this is people who are spending more cultivating the crops, watering them and harvesting them and taking them to market. They're not earning as much as what it's costing them, on top of the debt for the land that they've rented and the pesticides on top of it. So you can see a chain of events between finances, financial poverty, and a relatively small amount of money, the practicalities of people in rural communities. The availability of the means of harming yourself in India, widely available pesticides, relatively cheap and very harmful and very toxic. The staff in accident and emergency were that experienced. They could tell which organophosphate by the smell coming from the person as they were admitted into accident and emergency, which type, where it was. And at the time when we first started in India, trying to kill yourself was unlawful. It was a reportable offence to the authorities. So there were a lot of people who accidentally ingested organophosphates in hospital because it was a police reportable offence. It was a crime. You add to that that in some hospitals you have to pay for your treatment unless you're the most poor. Therefore, you've got poverty, you've got hardship, you've got stress, you've ingested pesticides, and then you may have to face the bill for your hospital treatment. So the chain of events we were really fascinated with, and we established the first community mental health team in southern India that worked over about a 4 or 5 hour patch from the city that we were based up in. So it's a significant global problem. 10.5 per 100,000 of population kill themselves per year. So these global rates differ considerably, to less than 5 per 100,000 to more than 30 per 100,000. And that's 2019, 2020 data. I don't want to speculate where these statistics are going to go, but I think you can say they're steadily going to rise globally. It's a global issue. It's throughout the person's life course, but 79% of these suicides occur in low to middle income countries. The major difference between high-income countries and low to middle-income countries is largely about younger men or more middle-aged men, where they originate from, where the bulk of it. But statistics don't really help us as clinicians or as researchers. They're facts, but they hide the individual. They hide the issues. And for me, I only ever get involved in research that clearly has direct benefit for the people who you are studying, the participants, the patients, the service users, their families. The impact when somebody takes their own life, it's significant for the family members and the aftermath, but no more so when the person is saved or revived or they come out of intensive care and they've got through it. Some people may think, I can't even end my life in the right way. I can't do that right. But again, this is a very individual choice, a very individual set of circumstances. It's a tragedy. No amount of theories or statistics will ever change that. The person may have reached the depths of despair. They feel shame, shunned, perhaps ostracized, as I mentioned in the case of the person we'd followed up in the first few slides. It's aligned to anger, confusion, grief, and perhaps loss. Think of the family members who also are there left behind and maybe don't understand the reasons why. They equally may feel that shame, loss, stigma, and isolation. What do you say? And if you think about people who you've lost, and my guess is you all will have known somebody who has perhaps ended their life or attempted it, you think about what we can learn from it and how we can actually speak or engage or say something. And sometimes you say, you know, I don't know what to say. I'm at a loss for words, and you just sit there and be with the person. So the journey out of despair may be long. It requires no amount of support, courage to overcome that, a lot of courage to overcome that from the individual, at an individual stigmatized level, but also at a society stigmatized level. The ideas, thoughts, and feelings of suicide and self-harm may coexist within the same individual. Myths, talking about suicide and self-harm reduces the risk. It does reduce the risk. People who attempt suicide are attention seekers. False. They're looking to communicate something with you. It's something far greater than attention seeking. It's an impulsive act. False. Not always. It can involve significant planning. But there's always a caveat. But some people do it impulsively, and we maybe don't understand why. There's nothing that can be done for somebody who's suicidal and wants to end their life. Again, maybe false. It may lead to support services. So it may be signposting. It may be spending that time that's invaluable for the individual. So the approach, some suicides are preventable at a national level. The inquiry into suicides and coroner's cases, so it's the National Confidential Inquiry into Suicides and Homicides, that's run out of the University of Manchester, highlights that liaison and communication can always be improved. I'm quite fed up, I think, with the amount of inquiries that said we should improve our communication. We should be able to communicate better. Why aren't we doing that already than needing an inquiry to be able to tell us that? And the care pathway required from intensive care through to psychological care, through to discharge eventually. So we looked at staff knowledge and attitudes, because you have to provide an intervention point, and we looked at a large group of staff within 2 Indian hospitals. Very few had received training in suicide assessment and management. Remember, this is general hospital staff. They were significantly higher positive in their attitudes towards somebody who had harmed themselves. However, if they had training or if they had had more training. So attitudinal change did work with training. We then looked at nursing staff and their views and attitudes towards people who had self-harmed, again in one large general hospital. We employed a qualitative methodology, and we did qualitative analysis following the transcripts that we'd received back from the nurses. And the conclusion there, following the nurses reporting a myriad of causes, weak religious beliefs, psychological weakness, exam failure, relationship failure. So this is the language that was used culturally that we analysed. And it allowed for us to progress a series of educational cross-cultural studies to look at how we might prevent these attitudes within the healthcare staff. You can be overwhelmed by the amount of projects when you're working overseas, but you have to focus on ones that you think are going to lead to change. So we could have picked any one of the intervention points from accident and emergency through to intensive care and beyond, but we had to pick a point that we think had a chance of working. We also started working in a prison where suicide rates in prisons were also on the increase. And I've worked in quite a few prisons within the UK, so I was able to bring that experience back over to a prison in India. And their care was comparable. Their care was good. There was one warder per 30 prisoners, and there was good amounts of intervention and care within the prison. I remember playing cricket, actually, within the prison there. That's coming back to me as I'm speaking as well. So we had a game of cricket over one day where we had the staff versus the prisoners, and we lost. This was another one about education and being prepared within that. You go into a small theatre where you think there's going to be maybe 20 or 30 people. There was 250 warders, no PowerPoint slides, and a microphone, and you go through a ceremony first of all. So I was quite shocked there, and that was the picture that we put there, up there. What we found, though, is that prisoners and prison officers were very caring. They just wanted the training. Thank you.